Joining me in studio is a highly experienced UK consultant urologist. So welcome to the podcast, Mr. Christofides.
Thank you for having me, Toby. It's a pleasure to be with you.
Thank you. Right. So would you just kindly introduce yourself to us?
Yes, my name is Angelos Christofides. It is a Greek name. My origin is from Cyprus. And I grew up in Cyprus, but spent the latest 2/3 of my age, let's say, in the United Kingdom, where I have trained in medicine and qualified and chose the world of urology to work in. This is a specialty which really allows me to be very closely to my patients and allows me to practice a lot of surgical skills. I'm a practical person who basically wants to educate people at the same time as treating them. And I do have a variety of interests in life. Sports is one of my interests. So very fanatical with Arsenal Football Club for any Arsenal fans.
Must be a very nice season for you this time.
It is a nice season.
So it's really nice to have you and to have that awesome introduction from you. Gives us an idea of what you are even outside the medical field.
Yeah, it's quite important really to have other interests than obviously your work, even though work is what drives you in life. It is your daily routine, which basically gives you the chance to interact, learn, evolve, educate, along with the family. So in the broader spectrum, my work is my family as well. So it's always good to be around there.
Yeah, and it's been a pleasure working with you as well. I know we've worked together quite a bit.
We do work.
It's always a pleasure having you.
My pleasure, Toby.
Yeah, awesome. Right. So if I may just ask, so I know the medical field is quite wide. Why did you choose urology?
I am a consultant surgeon in urology, indeed. The reason I chose urology mainly is because it's quite practical, but also it involves a lot of medical field, which allows people to understand the mechanics of their body. And urology more specifically because I feel that as we grow older, and this is a specialty which will keep me busy for years to come, because the range of patients are really from the day one of being born to the last day of someone passing away. And it is a challenging but very interesting topic with a lot of new developments, innovations, and a lot of pharmaceutical innovations, I would say. Very important for people to understand the basics to really involve themselves in the future management of their health.
Yeah.
And that is the main reason why I did it. At the same time, I thought that it's quite simple.
Mm-hmm.
Nothing is simple. Nothing is simple.
Waterworks. I think it involves really a wide range of issues, from kidney issues, bladder issues, prostate issues, UTIs, erectile dysfunction. It's really a wide range of issues.
Quite right.
So would you mind just giving us a brief of what urology exactly entails? And also,
Absolutely.
if you would like to have us focus on one area, you would feel free to delve into that one area.
Urology is a very, very vast section of medicine. I've already alluded to the fact that it's a medical specialty and a surgical specialty. If we start by the definition of the word urology, it is originating from the Greek urologia, And it has to do with the waterworks of someone, the genitourinary tract. And because the urine is in Greek ura, that is why it's the specialist of producing urine. Now, it covers the kidneys, the ureters, which are the pipes that then basically drain the urine from your kidneys, which are the filters of your blood, to the bladder, which is the storage area. The genitourinary system involves separate distinctions from a male to a female, and more specifically in a man, the prostate gland. That is a very, very important gland in men, as it contributes a very specific function, creates the semen or helps the semen to be of good quality to produce children. This is the significant difference, biological difference between men and women. Nowadays, there is a lot of changes in what we perceive as being a woman or a man. However, biologically, this specific organ does not change. And it is always in the interest of us to really identify significant diseases, and most commonly, which is the most recent development in news at the moment, it's prostate cancer. Prostate itself is not necessarily a cancerous organ, but as we age, it ages and causes different problems with obviously emptying the bladder or developing some cancer. This is more for the men. However, there are other conditions, for example, infections, urinary tract infections, that do affect and bother quite a lot, even the younger population and the female population. And they can be related also due to a large prostate in men. There are a lot of other conditions in specific for the male patients, such as erectile dysfunction or ejaculatory issues that can be considered as important, and we do deal with those as well. However, I think the one thing to discuss more specifically now, Toby, is the prostate gland and the prostate cancer.
Okay. It's a pertinent issue to discuss at the moment. Probably before we go into that, if you could just say something small about these other parts, and then we'll focus on the prostate. For example, in the kidneys, we would mention something about kidney stones.
It's very, very good idea to understand really the top to the bottom. The top of the system is basically the kidneys. Every person is blessed to have two kidneys. They are the two filters of the blood, which essentially produce not only the urine, but they also have the ability to create hormones and balance, regulate our salt levels in our body. They are very important as they have the ability to withstand great abuse occasionally from misuse of substances, medicines, and other conditions that affect the blood supply to them. However, they keep going until the point that really their function goes, and we have to support them by dialyzing the blood, meaning filtering the blood artificially to the point where a transplantation of the organ is necessary. So kidney stones, because you mentioned that, is a very, very interesting and very common condition, which basically is the creation of calcification. Calcium is a salt level, a salt substance that comes together with other salts, and if they're not diluted from chemical composition point of view, they come together, they concentrate and form literally stones. And these stones could be of different composition. They usually start from a small point, and the salt deposits on the small point. It could be a dead cell, it could be a bacterium, it could be something that floats around in the urine during the filtration process that causes this stone formation and expansion. If we do not drink water to flush it out, because our kidneys are containers as well as filters, they contain the first urine that is produced, then those stones will become bigger in size, different shape, and get the opportunity to lodge somewhere, and more specifically in the pipes on their journey towards the bladder. That's when someone would be complaining significantly of pain, which we call renal colic. A lot of people describe the pain as the worst pain experienced ever, and women have to say that probably feels even worse than birth or delivery pains. Yes, it's that bad, and it could be happening with knowledge or without knowledge, because our body is able to pass small stones without significant pain, and sometimes people can confuse it for significant back pain, which they believe may be the musculoskeletal in origin, the muscles and bones. However, occasionally this passage of the stone that causes also blood in the urine, which is a terminology that we use, hematuria, and that is also important because the GPs, if you do mention that, would have to investigate it because of the risk of development of other diseases.
Yeah. So would you say it's possible to have kidney stones and pass them without ever knowing that you had them?
Absolutely. The kidney stones can be of different size, and therefore that's why you can pass them. You would know if they were very big and blocked your kidneys.
Okay.
And occasionally you could get pain in your loin side, which is dull and constant. However, that could be for different reasons. It usually is at the back, and it is referred to the bottom of your pelvis.
And what would you say is the biggest cause or the predisposing factor to kidney stones?
So there are many. It's multifactorial. It is multifactorial. That means that it is not single one reason that you could have this. However, the most important reason is dehydration. Not drinking enough water to dilute what you are naturally intaking from taking foods, medicines and supplements. However, there is people that do have the genetic predisposition to have these problems, this creation of stones, and they also have anatomical differences than the majority of people that causes slower drainage of the kidney and therefore allows stagnation of the urine and formation of stones.
Great. So I think that's a good summary for that area. I think we'll not focus so much on that for today.
It is a big topic. We can have a different discussion another day.
Yeah, it's a huge topic, I know. But what I've taken from that is that it's possible to have kidney stones and pass them without knowing, depending on the size. And the most important cause or factor associated with the formation of kidney stones is dehydration.
Absolutely. Dehydration and excessive intake of salt.
Okay. Which could be in form of supplements or any food that you're taking and stuff.
Because it doesn't only cause the kidney stones, it causes hypertension, or it actually contributes to hypertension.
How about, because I know UTIs are really common. It's a really, really common problem.
The first thing that anyone needs to do when a patient attends the urology department is to establish that there is no urine infection. It is a significant problem because it causes a lot of irritation of the bladder, but also causes more dehydration. The infection essentially is a body's response against bacteria that can be living inside the bladder, for example. Those bacteria can start from anywhere in your body. You can ingest bacteria, you can have a little cut on your finger, you can have a tooth infection, and those bacteria can travel through the bloodstream as they're passing through your kidneys and the kidneys filter some of those bacteria that travel down into the bladder. And because the bladder doesn't empty immediately, they just find a very nice, warm and stagnant environment where they could really multiply. Once this happens, it can cause a significant irritation of the bladder and significant urgency to pass urine. When you do start to pass the urine, you may see that it is very difficult. And when you do pass, it's only small amounts. You don't feel completely empty, and you may see some blood. So that's going to be, alarming for someone. However, women tend to get this quite frequently, and this is because obviously their urethra, the water pipe, is significantly smaller than the males, the long pipe that runs through the penis. So there are two different reasons as to why men and women have these infections. However, because they're more common in women, we tend to talk to patients about hygiene and hydration and avoidance of destruction of the normal flora, which is the bacteria around the gynecological bits, the female parts, the vagina, because that section acts as a barrier towards bad bacteria that can travel from the back passage to the front passage. Hence, it is very, very important to teach even girls how hygiene has to be maintained to avoid transmission of the bacteria from the bad side to the front side. For the men, urine infections can happen, as I mentioned, because of many other sources. It could be because of a cut on their finger, chest infection, diabetes contributes to lowering the immunity and therefore gives the rise of the infections. So when the bladder is full of water and then the water has to travel through the water pipe, the prostate gland is located at the beginning of the water pipe at the junction of the bladder to the penis. And the size of the prostate really starts from being significantly small, non-existent from birth, to significantly bigger sizes and variable sizes as we grow older. And this is because of the effect of testosterone, which originates from our testicles. And this is differentiating us from females. Women do have testosterone, however, it is not significant enough to define the development of the prostate gland. And at the same time, it's aging. Because the more it's exposed to testosterone, the prostate gland, the more it grows. And it grows benignly in the first instance, which means it's not significantly cancerous in any way, but it can squeeze the water pipe and therefore strangulate it, if you would imagine it like a polo, which constricts, and therefore cause incomplete emptying of the bladder. Hence, the bladder then allows the bacteria to grow and therefore cause infections. At the same time, you can develop debris in the bladder, which is a very good bacterial food because you shed off dead cells and therefore continue to have these infections, causing bleeding and pain, incomplete emptying, unsatisfactory voiding. So these are these infections that one needs to exclude before further reasons are investigated. Not sure if you would like to talk about more specifically the pathology of the big prostate gland.
Yeah, actually, this would be an opportune time to now focus on the prostate because it seems to be really connected to all these other issues. First of all, so what is the prostate gland and what does it help us with?
So, as I mentioned before, it is a gland, it's an organ which is used it's part of the reproductive male system. Its job is to really mix the semen with a special substance called prostate-specific antigen, which is a protein that is created in the gland with the sperm that originates from the testicles. and with fluid that comes from a different gland called seminal vesicle, which is a very nutritious fluid for the sperm. The prostate-specific antigen, PSA, is the catalyst in making the gelatinous substance, which comes from the seminal vesicles, liquid. And this allows for the little swimmers, the sperms, to actually swim through the vagina when deposited during ejaculation. And it contains also enzymes. It is an enzyme itself, the PSA, which allows the penetration, of the mucus that the woman would have in their vagina. It is a gland that has two parts. One part is the stroma, which is the connective tissue that keeps everything together, and the little glands that produce the PSA, the prostate-specific antigen. Those glands increase in size and volume as we grow older because of the testosterone effect. And naturally, as we grow towards the 80th year of our life, the prostate gland will probably had the opportunity to live so long and change due to the wear and tear, I would try and say that way, and then cause some abnormal growths, which is what we call cancerous growths. So by the age of 80, probably 8 out of 10 men would have some cancer in their prostate, whether it is significant or not. That is not possible to establish unless you have some indicators. And this is where we use the blood test PSA to identify significantly changed prostate glands.
So in terms of diagnosis, how do we identify the risk factors? So you've mentioned that age is one of them, is the major risk factor here. So as from what age should we start being concerned, or having probably annual screening or regular screening?
It is very controversial in the sense that if all men were to start to screen themselves for prostate cancer from a very young age, what they would be left with is a series of tests which potentially will not give information about prostate cancer. And for that reason, the age that one would be mostly concerned and probably advised to investigate themselves about prostate cancer is the age of 50. At the age of 50, it's where you have the most significant changes of your life, since we call it midlife. That's when everything changes. Essentially, by the age of 80, as I've mentioned before, 80% of men would have prostate cancer. However, there are other ethnic groups that really can affect their risk in developing prostate cancer. But not only that, their family history. Afro-Caribbeans and people who have had family history from a first relative degree patient of prostate cancer have at least 2 to 3 times increased risk than a normal population white male person to have prostate cancer. In addition, more research has been done over the last 10, 20 years, and there has been obviously identification of genetic markers, DNA samples with genes that relate prostate cancer to breast cancer. So if you had not only someone who had prostate cancer in their family, but also females with breast cancer, then you have a risk of 2 to 3 times of having prostate cancer yourself. And the younger you are, the more advisable it is that you go and check yourself out. The older generations, as I've mentioned before, a lot of this prostate cancer can develop spontaneously and naturally. Hence why we say someone who's in their 60, they should start checking their PSA. However, 50 is the general advice because we do not know who or who hasn't any family history.
Okay. Great. And I think this is really a significant problem. I saw somewhere in the news that quite a number of celebrities have been affected by this. So it really is a pertinent, important problem. Yeah.
Yeah, it's a current but long-lasting problem. It has been there for years.
Yeah.
However, the knowledge is only just obviously increasing because of the amount of expertise that we develop, a lot of new research, and a lot of patients now being more aware, therefore attending for the test when previously they were ignorant about it. Now there is a lot more awareness through the social media and clearly the TV. Big personalities, and the most recent victim of this is our ex-Prime Minister, David Cameron. And obviously this shines quite a bit of light on the urology field now, because prostate cancer is something that can be cured, not just observed and monitored. It is currently in the news as well, the significance of screening for prostate cancer, like breast cancer. Patients get screened. Why not offer this screening to younger men as well, or all men? And the trouble is that it is a very expensive thing to do, to the expense of side effects of any treatment for prostate cancer that is not necessarily significant and life-threatening. Hence, there is a lot more importance in educating people to make them understand what may benefit them by testing or not testing their prostate-specific antigen.
Is there a point where we can say it's absolutely treatable and a point where we can say it's not treatable?
Certainly. Any cancer development, any cancer disease usually starts from being a normal substance, a normal tissue, a normal cell, and changes its characteristics into becoming a little bit rogue. And prostate cancer is a disease that takes years to change, years to become aggressive. And the aggression is translated in spreading in other parts. First of all, it can spread locally outside the prostate gland, which anatomically, for people to realize and understand, it may start from being a small chestnut in size, change into a small tangerine, a little bigger, an apple. It can go to a big orange and even bigger than that. Now, it's natural, if you consider the size of the prostate, that at some point within that, some cells may go astrange and then become cancerous. They may change. They may have mutations in their genetic code. And those cells take time really to multiply because of the effect of testosterone on them. So the longer you have the prostate cancer, the more chances those cells will become more aggressive. And the aggression they show, as I said, is that they influence their neighboring cells towards the outside, the periphery, the external parts of the prostate. If they manage to penetrate the external parts of the prostate, then we say that the staging is advanced because it has breached the boundaries, and that causes us some limitations in how we can treat it. However, that is possibly treatable as well and curable. If those cells, though, develop so much of a characteristic where they can easily spread through the bloodstream or the lymph nodes, they could certainly spread into other parts of the body. The most common areas that they spread to is the lymph nodes and the spine. And if the disease in the spine is existing, then the treatment could still be given. However, the cure is unlikely. The idea is to identify the prostate cancer at a very young, early stage, let's say, where we can remove. At the moment, the research has allowed us to provide new innovations and new treatment options where we can remove little parts of the prostate using ultrasound. However, the more tumors you may have in your prostate gland, the more limitation you have in treating. Therefore, collective removal of the prostate, called radical prostatectomy, may be offered. And this aims to really take away the risk of those cells spreading outside to other parts of the body, which you cannot surgically remove. But you can certainly treat them with medical means. Therapies, drug therapies, specialist drugs, but above all, switching off the testosterone from being produced and act upon those cancer cells. So the medical terminology for that is castration. In the past, it used to be that we had to remove the testicles altogether, and people were actually castrated. And nowadays, it's extremely rare that anyone can offer that. However, it is the basis of the treatment of prostate cancer to switch off the fuel, which is the testosterone. We know that boys do get growth spurts, and they have 2 spikes in their testosterone production. The first one is in utero, and the second one is when they grow outside the utero in the first 3-4 years of their life. Then they get puberty, and the puberty is the one that obviously ignites the prostate gland development. By the age of 18, you would have a very small prostate of about, in cubic centimeters, if you consider that as a small sphere, your prostate, maybe less than 20 cubic centimeters. However, the older you get, a few cubic centimeters per year increase occurs, and that obviously increases with the steady amount of testosterone that someone produces. Now, if someone in this new day and life that we live was to abuse testosterone steroids, anabolic steroids, they could certainly cause or accelerate the growth of their prostate. And if there is any predisposition for that, prostate cancer development, that can certainly ignite and occur. Now, there are men that do have lower testosterone as they grow older because they are unfortunate, for example, to have some sort of injury to their testicles or indeed some chemical and viral illness. Mumps orchitis is one of those that can cause really destruction of the testicular tissue, especially from younger age. And as one would expect their testosterone to really rise in the future, it doesn't, and therefore they have some potential issues with fertility, secondary characteristic development, that is beard, masculine features, and so on. Those people may not develop prostate cancer. However, it is not known unless you were to test their prostate, because there could be sporadic changes. There could be the genetic changes that we have aforementioned that could contribute to the development of prostate cancer. But whether it is aggressive or not, it's very difficult to predict.
Wow, okay. So despite the reduction of the testosterone produced, still it's enlarging, but at a slower rate.
At a very slower rate, it's still present.
It's still present, yeah.
It's still present, yes. It does not involute, it does not disappear at all. And that we know from the special cases of sex change.
Okay.
Because a lot of men would take anti-androgens that obviously feminize a lot of our characteristics. However, their prostate gland may not disappear, but it might shrink a bit. Even in those cases, though, cancer can develop.
But I would assume it would be much less likely than the general population.
much less likely, indeed.
Yeah. And so you say, I know anabolic steroids and artificial testosterone is quite common nowadays. Would you say it's associated with increased risk of prostate cancer?
It certainly increases the risk of prostate cancer. Because, as I mentioned before, the pathogenesis of prostate cancer, how it is being created, is by the cancerous cells utilizing the androgen receptor to split, multiply, and therefore cause more mutations, which is why cancer is uncontrollable. It's escaping the mechanism of the body to try and kill those cells, and therefore they multiply and they become malignant entities.
Right. So I would like us to talk about something about the diagnosis, and then we will talk about treatment options. So first, in terms of diagnosis, what are the hallmarks of diagnosis of prostate cancer?
So the first thing that one needs to do when they're concerned about prostate cancer is ask their GP to discuss with them the blood test which detects the PSA levels in their blood. PSA is the protein that I mentioned, the prostate-specific antigen, which if it is significantly produced, can be detected in the bloodstream. Naturally, we do have an allowance of how much can be detected in the bloodstream, and we do understand that the production of that also is associated with the use of the testosterone of the prostate gland during ejaculation. So people who may have sexual interactions, if they were to test their blood test when they have just ejaculated, we would see a significant spike of the blood test. Therefore, it wouldn't be reliable. It is a test that has to be done when a man has abstained from ejaculation for at least 3 days. When this has happened, we do measure the value in the bloodstream, and different age groups allow different cutoff limits. And the reason for that is naturally, as I mentioned before, the size of the prostate correlates to the amount of production of testosterone. So the younger you are expecting to have a smaller prostate gland, therefore less production of the prostate-specific antigen, which can be less detected in the bloodstream. The older you are, the bigger your prostate gland, the more likely to have more PSA production, and therefore the levels that one would have to consider there vary on the size of the prostate. However, in the general population, and as a guidance for the GP, we have provided the Urological Society, and internationally, it's recognized to be the value of 4 nanograms per deciliter. And this allows you to really have a referral to the secondary care, which is the hospital doctors, really, to have further investigations. Traditionally, we examine the prostate, and we examine the prostate with the finger, digital rectal examination. It is an uncomfortable procedure to do.
Yeah.
However, it is necessary, and it gives some form of information, which for the medical specialists is very important. However, it is one of the 2 tests that we offer to initially instigate whether we proceed to the very good test called MRI scan of the prostate gland, which gives us a very nice overview of the characteristics, size, and nature of the prostate gland.
And it shows the different areas as well.
Absolutely. It does have, anatomically, the prostate gland has got different areas, and it's the outside area called the periphery, and the inside, which is the transitional zone. This is the zone which increases in size more than the periphery. However, overall, the prostate gland increases because of the testosterone. Now, the peripheral zone is the most likely area where someone would find prostate cancer, and hence it is the area we examine when we do the DRE, the digital rectal examination. There are areas that we cannot reach with our finger, and naturally we do need this MRI scan because it gives us more insight. And as you quite correctly said, Toby, it gives us the black and white areas which make the difference and allow us to target them by taking little samples with a needle called, as a process, biopsy. Biopsy is the most definitive diagnostic tool that we have for prostate cancer. However, there is always risks with that, missing some cells or small areas that were not seen from the MRI scan, or indeed our needle did not reach specifically to see them. In general, it's a combination of all these measures that gives us an insight as to whether a cancerous process is ongoing or not. When we do analyze the cells, then we see whether they are falling into a group of a category of risk of the cancer being aggressive or not aggressive. So there are 3 risk categories, or 3, which one of them subdivides in other 2. We have the mild risk cancer, the intermediate risk cancer, and the severe risk cancer. The intermediate risk cancer can be divided into the early intermediate, which means mild to moderate cancer, and the moderate to severe cancer cells, because this is done with the specific measurement of the numbers of the cells and the nature of the cells under the microscope. For our audience, it's the Gleason score. This is what we use to cause this characterization of the prostate cancer. In addition, we have to have more information by checking and excluding that there is no spread of any cancer outside the prostate by obtaining a scan of the bones called the bone scan. It's a radioactive test. And then this allows us to exclude metastases or metastatic disease. And that allows us to stream towards the different treatment options. I can expand, if you wish, on the treatment options of the different kinds of prostate cancer.
Yeah. Actually, before the treatment options, so it's a filtering process. So the first and most common first point of contact is the PSA. The PSA will give us a general direction, and you've said the PSA could be raised due to factors other than cancer. It could be due to if you've just had an ejaculation within the last 3 days.
Correct.
And then it could also be because of infection or inflammation. Yeah. So PSA alone is not definitive. So in addition to that, we do an MRI.
We do an MRI to confirm the looks of the prostate, the anatomy, the characteristics that the prostate has. And then we use that to be directed towards having a biopsy of the prostate or not. Because the biopsy is an invasive test and it can cause a bit of discomfort. And that usually we do with local anesthetic nowadays.
Yep. Yeah, I know previously was it?
Through the back passage. That's called transrectal. Yes. Whereas now it's within the area between the scrotum and the anus.
Yes.
And that area is called transperineal.
Yeah. Right. So we can go into the treatment options, if you could expound a little bit on that.
So again, it is very important to have all these characteristics, because then the doctors would take into account also the patient's characteristics, their age and their comorbidities, their ability to sustain prolonged surgery or prolonged therapeutic treatment with radiation therapy. Also, we understand by reviewing the heart and lung conditions whether one would sustain the nuclear option of chemotherapy in the event of metastatic disease. And it is this that we need to know before we even commence any investigations for treatment. The reason for that, Toby, is that if someone is in their late 80s or 90s with a lot of comorbidities, the question arises as to, is there any reason or good excuse to subject someone to investigations that potentially have side effects and might limit their quality of their lifespan and its quality of life, which is more important towards the latter stages of life than just treat them with the medical therapy of androgen deprivation, which is the hormones we use to stop the production of testosterone and chemically castrate them. That treatment option alone is called watch and wait. And this is a process that we offer to the unfit people, the people that cannot withstand significant insult to their body. The people who are younger and much more fit, obviously, depending on the characteristics of the prostate gland and the cancer, whether it is just confined to the prostate, could undergo treatment by removal of the prostate, which is what we call robotic. Well, we use robotic means, keyhole surgery, to remove the prostate gland, and that is called radical prostatectomy. Or whether we can treat them with specific, focused, intensified, interrupted amounts of radiation therapy to sort of cause cell death and scarring of the prostate gland and eliminate the chance of the prostate cancer spreading and growing. There are other means, as I've mentioned previously, that we can use to specifically for the younger men who are really concerned in keeping their prostate gland and maybe ejaculatory function intact, by using intensified ultrasound, high frequency intensified ultrasound, to treat small areas of the prostate gland with prostate cancer. So what is very important is to understand really at what stage is the prostate gland and whether it is localized, locally advanced, or metastatic. Yes. Because there is different treatment options for all these. The ones that are really giving the doctors a bit of a headache, in the sense it's complicated, are the ones that are locally advanced or not locally advanced prostate cancers, and essentially with the features that borderline metastases. Okay. And that's where a combination of treatments with surgery, radiation, and medical management, chemotherapy agents are utilized. And it's a combination of ideas and contribution from the surgeons, medical oncologists, and radiotherapists that this is provided. So the management plan is not one person's decision. It's a collective decision which stems from the multidisciplinary team. And at all stages of this diagnosis and treatment, we support the patient by giving a lot of information and bringing them to groups of patients with the same disease and treatment that they had undergone for psychological support, and by providing them constant input from the Macmillan nurses, who are very good in encouraging people and finding solutions for issues that prostate cancer creates outside their body, in their life, in their social life.
Yeah. Wow. That's comprehensive and concise at the same time. So that's great. Just to summarize that, we have watch and wait. We have radiation therapy. We have surgery, which are different types of surgery. And we have the chemical castration as well as one of the options.
And we have the last option, which is what younger men prefer to. Younger men who have mild degree of prostate cancer, active surveillance. And that involves having the blood test repeated in a number of months every year to ensure that there is stability of that. Okay. If there is any change, then obviously we have to characterize the prostate cancer again.
Yeah. And throughout the process, the patients are supported appropriately.
Correct.
And in terms of the surgery, I know there's the HOLEP.
In terms of the surgery has the aim to provide two outcomes. The first outcome is to address the issues with emptying the bladder. We know from the size of the prostate that a lot of men will be suffering from, increased frequency, urgency, reduced flow of urine, and therefore destruction of their social life, especially at nighttime. They can wake up and not have sufficient sleep and make them tired. And this prostate gland can be treated medically by giving medicines or by removing part of the prostate. Remember, I mentioned before, the inside of the prostate is the central zone, the central transitional zone, which is what grows to cause the strangulation of the urethra and therefore the urinary symptoms. If we do remove and we core, if someone can imagine an apple, if we core the inside of the apple, then we create a big channel where the water can drain out from the bladder. That surgery can be done in different ways and different means. You mentioned HOLEP. HOLEP stands for hormone enucleation of the prostate gland. It is an energy source that we can use, light, to remove the inside of the prostate gland and core the inside like the apple, where then we take away the tissue, we send it off to the lab, it analyzes, and then we can tell you whether there is or there isn't cancer and the type of that. However, it is not the treatment to cure prostate cancer. It is a treatment to essentially improve the quality of life whilst you're going to have more treatment options such as radiation therapy. And essentially, after any surgery to the prostate, which is for the waterworks issues, you have a catheter. You could have also the radical prostatectomy, which aims to remove the whole of the prostate and breach the gap of the bladder to the water pipe by joining the two and put stitches and closing it together for things to heal, and leaving through the middle of that another catheter to drain the urine and stop it from leaking out. These are temporary measures so that we can allow the healing process to occur and therefore meant to have better flow of urine. There are risks with these procedures, like with any surgery, and people may be more concerned about the continence and the ejaculatory function and the erectile function, which are risks of this procedure, mainly because of the destruction of the prostate, but also the use of energy to really stop bleeding. And at the same time, as a consequence, destruction of the nerves that supply the function of ejaculation and erection. Bleeding is also an option that has to be discussed, because in the past, Toby, the surgery was mainly done through the urethra, transurethral resection of the prostate. However, the technology means were not as advanced as nowadays, and bleeding was a significant part of it. And people were very much afraid of having surgery because of the fear of bleeding to death. Naturally, not many people died. However, a lot of people were complicated and had issues with this. At the same time, a lot of knowledge has improved and has been gained to allow us today to use very minimal and sparing procedures to allow for better continence and better erectile function and better ejaculatory ability.
So just one clarification on that. So after, for example, radical prostatectomy, will the erectile function and ejaculatory function remain?
So when we radically remove the prostate, the intention is actually to cut the section and all the prostate and its surrounding tissue out and remove it from the body. When you remove that, then you lose naturally the effect or the contribution of the prostate. Therefore, your ejaculation will be gone. You will lose the ability to have children. Depending on how significant the prostate cancer is and whether it's towards the very outside of the prostate or not, really matters for the surgeon, because for the benefit of having a lower risk of recurrence of the prostate cancer, the surgeon would like to remove more tissue from outside to not allow little cells to affect the periphery, the surroundings. And by doing so, you can affect the nerves that actually are running tangentially by the prostate gland to provide supply to the penis. And if you do injure those nerves, then your erections are affected. If the prostate gland cancer is very well confined and towards the middle of the prostate, then we can spare the nerves, and about 90-95% of people have recovery of their erections nearly back to normal, but with maybe some help.
Oh, that's good. So it's still possible to have erections without ejaculation?
Absolutely, yes.
Okay. Wow. So that's really informative. When it comes to the chemical castration, that I believe that is confined to the testicles and it does not affect anything else.
As men that we are, our driving force, or our the hormone that we use to really feel men, and that could be sexual drive, anger, hunger for sports, hunger, real hunger. It's down to the testosterone. You see, the male body really depends on testosterone. That's why we have bigger muscles, bigger features than females. And when we do castrate someone, we have to really eradicate the testosterone from their body, because the slightest amount of testosterone will drive those cancer cells. So when we try and castrate someone, is so that we reduce their testosterone to extremely low levels, where we say near zero. Now, the testicles are the main production units of testosterone, but we do have also testosterone arising from our adrenal glands. Now, the adrenal glands, though, are not significantly testosterone producing, and they can be switched off if our brain adrenal signals are switched off. And usually, by chemically castrating someone, what we tend to do is that we switch off the brain signals to the testicles, which naturally use that signal to produce the testosterone and the sperm, to switch off and therefore not produce any more testosterone, because there is a brain, testicle, and adrenal cycle. So if you disrupt one leg, then that brain does not send signals to the adrenal glands to produce any testosterone. Now, naturally, when you deplete the testosterone altogether from someone, all the aforementioned, features that I mentioned will occur. So a man will start feeling, for example, hot flashes, because what happens is that the estrogen part of their adrenal glands will produce and therefore drive them. We're not becoming women, however, we have some features that we can understand women with. Increased appetite. Women do tend to put on weight after menopause. The mood can change. Men do need testosterone to feel men. When you deprive that, then they can be a little bit depressed, where we say there is also hot flashes. There could be a little bit of breakdown of communication and lack of sexual drive. It's extremely rare, but some men do develop some breast tenderness. And if that happens, then of course we can use other medicines to try and stop the growth of the breast tissue that potentially is growing and is causing this pain.
Okay. Right. So I know erectile dysfunction is a totally different topic and it requires its own time. But when you say reduced sexual drive, is that similar to erectile dysfunction? It's the same thing, one and the same.
Erectile dysfunction is a more generic term, okay? It's an umbrella of meaning. Some people may refer to it for when they cannot have a good erection, a good, powerful erection for penetration. But there is other people that express that term when they feel they do not want to have sex. And that feeling is the libido. So libido is the sexual drive. It's where you see, smell, think of something, and you then get an erection. If you do not have the testosterone which really stimulates your brain in that fashion, then you will probably not have that thought process, smell process that gives you the erection. And therefore, you do have erectile dysfunction as well. Ejaculationary dysfunction is another terminology for the inability to inseminate, which means ejaculate the sperm that your testes produces, okay? And that happens also in younger men without having had any testosterone derangement. Usually, 98% of the times, is down to the psychology of the person. And that is why psychologically men may also be affected in having the urge to have sex, the libido as well. So it is a big topic. It can be discussed in a different session if you wish.
Yeah.
However, it is a problem that men do not wish to have. And I understand that. It's a balance, though, between life and quality of life. And this is what we need to educate people
Exactly.
about.
Wow. So that's powerful education there. I think there's one thing we have not touched on, and it's a process that very many men across the world go through, and this is circumcision. And most of the time, it's because of rites of passage, but it can also be medically prescribed for some issues. So would you mind just giving us a wrap-up, a summary on what circumcision really is and why it's important? Is it important, first of all, is it really important for someone who does not have issues?
For the audience to understand the anatomy, the penis is basically it's the organ that we use, obviously, for penetrating a woman having sex. And it is covered by skin, as it is a projection of our body. The skin covers the head of the glands of the penis as well. That skin, potentially, in younger life, can be overgrown. And as it overgrows, it causes issues with, for example, stasis, stagnation of urine, and can cause diseases of the skin. One of those diseases is called lichen sclerosis or palanitis xerotica obliterans, which means that the skin obliterates by becoming scarred and very tight, and people who attempt to retract their foreskin cannot to do so to clean, and therefore it can split and it can cause bleeding, pain, itchiness. If left untreated and with a chronic exposure of urine, which does not clear out because of the inability to clear it, this is a premalignant condition. It can turn into cancer. Now, you spoke about some reasons of someone to have circumcision, and circumcision is offered for religious and medical reasons. However, if someone has not had their circumcision in younger age and they're unable to retract and they develop the disease that I've mentioned, then we do suggest that they do have circumcision. In Africa, it is very common and standard practice, but not only just Africa, in many countries around the world, where the foreskin is removed, and this is the procedure called circumcision, to technically remove the distal part, the last part of the testicle, which covers the hood, if you want, of the penile head, to remove it and allow and expose the glands to the air so that it's easier to clean and allow less bacteria or viruses such as HIV or human papilloma viruses or syphilis to be trapped and therefore cause in the future changes, cancerous changes that may require further treatment of the penis itself. So circumcision is a medically indicated procedure if the penis suffers from this condition, the penile skin suffers from this condition called xerotica obliterans, lichen sclerosis, because it causes phimosis, closing down to the point that it may completely obliterate the urethra, the opening where the urine would come out, and cause someone to really go in retention of urine, which is a painful condition and potentially life-threatening if the kidneys do not function because of the pressure that builds in the bladder. So the medical conditions for circumcision are precancerous conditions or cancerous conditions, and for hygiene.
Awesome. I think this has been quite a power-packed episode. What do you think we make this a monthly podcast?
That would be amazing. That would be amazing. There will be a lot of information we'll have to share with people.
Thank you very much. I don't know whether you have any closing remarks.
No, Toby, this was a pleasure to have spoken to you today. I've got the platform to really explain things that a lot of men need to know before they embark in the journey of prostate cancer, and obviously educate as many as possible to look into it specifically if they are of African origin, they have family history of prostate cancer, or they are young with bothersome symptoms that potentially may be a reason to consider prostate cancer. Not a common disease of the young, but not unheard of. As we know, Chris Hoy, the esteemed Olympic winner, cyclist winner, has in his family. Again, that is because of genetic reasons. However, it's not a bad idea to have yourself checked. We can talk about many other procedures and conditions in the future, and I'll be very happy to answer any questions.
You mentioned something and it just struck my mind. Cycling. Is there any particular risk associated with cycling?
There is no clear indication that cycling itself is a cause of prostate cancer. However, there is a very logical association that people make with prostate cancer, in that a lot of men who cycle may have a higher PSA, and that certainly puts them in that risk category if we use the thresholds, because they breach that threshold, that may push them into investigations for prostate cancer. Majority of times, a lot of men do not have prostate cancer, however, their PSA may be elevated. Why would that be? It's difficult to know. However, logically sort of speaking, one would think that the repeated forceful pounding on the saddle of the bicycle, or even the temperature in the area of the perineum, may increase. That causes more breakdown of the cells and therefore more release of the PSA. The evidence we have is anecdotal.
Great. So that brings us to the end of today's episode. A huge thank you to Mr. Christofides for sharing such a clear and honest insight into the world of urology. If you found this episode valuable, make sure you subscribe to Eureka Health Podcast. Stay informed, stay curious. Adios. Thank you.